So this panel discussion is public mental health models. On the program, it's scheduled to run from 9 until 10:15. We're about 15 minutes behind, so not to be inflexible on the time frame, we'll extend that by 10 or so minutes. And then I'm going to introduce our two panelists, Crick Lund and Umesh Bawa. Crick is a clinical psychologist by training, having obtained his professional master's degree from Rhodes University and his PhD from UCT. He's attached to the Alan J. Fletcher Center for Public Mental Health. It's a collaboration between UCT and Stellenbosch University, and Crick is also now attached to King's College London at the Center for Global Mental Health there. His research areas are mental health policy, as well as social determinants of mental health in low-income countries. And he told me outside that he's also a weekend surfer. So, global public mental health and surfing are the two standout variables. Thank you for not being at the beach.
Sure, it was a tough call.
And then Umesh Bawa, okay, hi Umesh, hello. So Umesh is also a clinical psychologist by training, having obtained his professional master's degree from Wits University up in Joburg. He is currently a senior lecturer in the Department of Psychology at the University of the Western Cape, and his area of interest and research is focused on the ethics and human rights paradigm centered within community-based care programs. Furthermore, he also does research in the area of youth critical consciousness and his interface with socio-political discourses. And then he has an interest in the training models for clinical psychology within the South African context. So Umesh, thank you also for being here.
Well, good morning everybody. Thank you so much for the invitation. It really is a great pleasure to be here, to see so many familiar faces, old friends from various places. And thank you very much indeed to Dane for organizing this and for really creating the opportunity for dialogue really between people working in psychoanalytic ways of thinking and those of us working in more sort of public health approaches to mental health. And I think these conversations are long overdue. One of the things that was so great about the last couple of days in which we had this psychotherapy symposium was that we brought into the room people who are doing some very creative, cutting-edge randomized control trials using non-specialist community health workers to deliver basic counseling interventions for people living in low-resource settings, and a whole lot of practitioners and policymakers. So I think the more we can open up the dialogue, the more that we can start developing a shared language. When I say efficacy, does that mean what you think it means? I think the more we can do this, the better. So thank you very much. So I'm going to be giving you just an introduction to this broad field of public mental health. And this is an outline of my talk. I'm going to be giving an initial set of definitions of what are the core concepts in this field. Really, I think quite an exciting and emerging field, very closely aligned to broader global developments in the field of global mental health. Then I'm going to talk a little bit about some of the context, the burden of mental disorders and the budgets and some of the constraints we face, especially in low-resource settings. I'll then share with you some of the recent developments since the year 2000, some very exciting developments in the field of global mental health, trying to develop new models of working and new evidence emerging both about the burden but also about cost-effective interventions. And then we'll bring it closer to home and speak about the South African mental health policy developments over the last few years and where we are currently with the new national health insurance initiatives. And then I'll share with you some of the work that we've been doing on the PRIME Consortium, which is a DFID-funded research consortium working in 5 countries. And one of the sites is here in South Africa. And the work we've been doing in South Africa here is very closely aligned and trying to engage with the national health insurance discussions, really trying to develop a model of care at the district level, which is aligned with the NHI. And then I'll be sharing with you one slide which I borrowed from Tracy Naledi, who's our Chief Director of Public Health Programs in the Western Cape, and who spoke to us on Thursday morning. and put up a sort of potential model. So these are all really models for discussion and debate, and I look forward to hearing your thoughts about all of this. So what is public mental health? What is this thing all about? Well, I shamelessly filched this definition from the School of Public Health's definition of public health, and wherever I found the word public health, I inserted the words public mental health, and it works amazingly well. So it's that aspect of mental health whose unit of analysis is a population or a community rather than an individual or a patient, and whose field of investigation and action includes promotion of mental health, the measurement and prevention of mental disorders, and crucially the fostering of equity, efficiency and effectiveness in the provision of mental health services. So I often say when I'm teaching this to students, imagine yourself sitting in the consulting room with your client or with a family, and then getting in some kind of lift or helicopter and kind of zooming up to the geographical level and looking at the broad context within which that person first of all lives, how they got access to care, what is the broad healthcare system within which you are operating, what are the policy decisions which made you end up in that particular position, what are the social determinants that influence how that person experiences mental illness, their cultural environment, their experience of poverty or violence, their experience of food insecurity, their experience of inequality. Are they on the lower rungs of the socioeconomic spectrum, and how does that affect the way they feel about themselves and their mental health? So it's really trying to broaden this whole field of inquiry. And I think a good place to start, here we are in the Western Cape, is to start with the Western Cape. So I want to just open it up here. So if you think about mental health in the Western Cape, what do you think are the main population level drivers of mental health among our communities in the Western Cape?
Violence.
Violence, yeah, okay. And can you tell me more about violence? Where do we find more violent communities or less violent communities?
Usually associated with poverty, lower
Right.
socioeconomic groups.
Right, okay. So we can often locate on geographically actually where violence is clustered. We know, for example, communities like Hanover Park and Manenberg, very high levels of gang violence, so that's going to have a big, big impact. And we know, for example, if we just take perinatal mental health, very, very high rates of antenatal and postnatal depression at the Hanover Park midwife obstetric units as a result of experiences of violence and insecurity, continuous trauma, not just single events. Okay, violence is one big one. What else?
Substance abuse.
Substance abuse, yeah? Can you say a bit more?
Well, also, I think in the areas like Hanover Park,
Right.
the poorer areas, yeah.
Right.
Huge amount.
So it's often clustered around particular communities. Also, and here's a little clue here, Cape Winelands, right? We have one of the highest rates of fetal alcohol syndrome in the world in the Western Cape. I mean, it's astonishing, and that's very much driven. So when we think about substance, not only drugs, but also alcohol, and how alcohol has historically been a currency, and that drives a lot of mobility. It also drives a whole lot of other public health concerns. So domestic violence, very much driven by alcohol, right? Okay, so we've thought about substance, violence, what else? Unemployment, yeah. Can you say a bit more about that? So how does unemployment affect mental health?
Well, I mean, I guess you're unemployed, you don't have food, you don't have money for food.
Right.
And that surely must drive you either to drink or to violence.
Right, exactly. So these things are often all linked and quite closely clustered together, and we often see in single communities a clustering of a whole lot of problems. So unemployment is very strongly linked, especially among youth unemployment, to gangs, which are linked in turn to violence and substance abuse. So we see when we start thinking about things from a population or public health point of view, we see some of these problems really cluster in particular communities, and they're driven by things that interact with each other. Anything else? Single parents. Can you say a bit more about how that affects your mental health?
I mean, I think combined with the things you said,
Mm-hmm.
the implications for neglect
Right.
just increase.
Right.
And I mean, emotional neglect in terms of parenting.
Absolutely. And we know from epidemiological studies that support is a big, big driver of depression, again, in the perinatal period. So these very nice studies which Mark Tomlinson and Leslie was also involved in in Khayelitsha, looking at the prevalence of antenatal, postnatal depression, social support. So single mothers, a very vulnerable group. So again, when we're thinking about things from a population or public health point of view, we want to identify vulnerable populations, people for whom we could potentially introduce interventions that might reduce the population level burden of mental illness. Okay, so we've got some really nice ideas so far. Anything else? Yeah.
Just starting from the geographical, there's this massive inequity between the rural and urban. I mean, I'm sure
Right.
some rural centres there are amazing projects, and there's amazing, one reads about these amazing hospitals in rural areas sometimes doing fantastic work.
Sure.
But we've got this massive disparity all the time. So that's just starting from that.
Absolutely, absolutely. So the whole issue of access to services is a big driver. So if you go psychotic in Ceres, for example, or you're suicidal in Dar or wherever, where do you go and how do you get access to care? And historically, most of our resources in South Africa have been concentrated in psychiatric hospitals. So we did a survey in 2007, and even at that point, 56% of the beds in the whole country, mental health beds, were in psychiatric hospitals. But if you look at the way in which deinstitutionalization has happened, especially in many high-income countries, a lot of those psychiatric hospitals are being closed down and beds have been shifted to general hospitals and to community residential facilities. So access is a big one. Something which, and I'll speak a bit more about the mental health legislation in a bit, but something which I think has started to shift that is this requirement to have 72-hour observation facilities in district and regional hospitals. So that's legislated that people have to be admitted first there before they can be referred through to tertiary centres. And if you speak to Pete Milligan, who's the head of the Falkenberg Psychiatric Services, he says 70% of the admissions which used to come through to Falkenberg are now being admitted at the district hospitals. That hasn't been without its problems, without teasing problems. It's an attempt to try and decentralise. So access to care is a big issue. And it has an impact on the course of your condition as well, as we know. So if you have an episode of psychosis, if it's treated earlier, you have a much better long-term prognosis. Okay, anything else? Sharon?
First, I think an issue like gender that affects the whole lot.
Right.
So with violence, there have been lots of reports about gender violence towards women.
Right.
Unemployment impacting on self-esteem of men who then will be violence in affluent areas which you might not detect that's gender-based due to XYZ. So gender, I think, is a big issue.
Definitely, yeah. And gender cuts across all of these issues, and vulnerabilities related to gender then intersect, for example, with poverty and violence, as you say. So we know, for example, from the SASH study, which is our only nationally representative psychiatric epidemiology study, that women have around the twofold risk of depression and anxiety disorders compared to men, and men have around a twofold risk for substance abuse compared to women. So when we look at the prevalence, it's very gendered around specific disorders. Yeah. Okay. So I think I'm just trying to introduce you to, let's think about things from a population point of view. So if I'm a policy maker, then how would I start to think about, first of all, the social determinants of mental health, the upstream risk factors which might influence mental health, and then how do I think about the best models for providing care to populations? Sorry, Dave.
I was struck day before yesterday that Tracy said, Tracy in a letter said, a lot of the people that were presenting were on investigation, not having mental health problems, but having social problems.
Right.
Now, I thought that was a very interesting statement.
Mm-hmm.
So there seems to be a real distinction between mental health problems, and of course there is, I'm not being churlish,
Yeah.
there is some distinction, but there is also, it's also an ideology to say that there isn't. That there isn't a distinction.
Yeah, I mean, it's a really interesting debate, actually. And I have a slide where I was thinking of putting up, but I didn't. But we've been doing some work over the last 5 or 6 years trying to develop a counselling intervention in Khayelitsha, which I presented on Thursday, using non-specialist community health workers. And as part of the development of that intervention, we interviewed a lot of women about their experience of depression during the perinatal period. And their experience of depression is completely tied up with their experience of social adversity and poverty. So not having a house, being a migrant person from the Eastern Cape without family ties here, domestic violence, all of those, poverty, food insecurity, all of those things are social problems. But of course they manifest in full-blown symptoms of major depression. So I think it's very difficult to actually separate those things out. And we know that there's a very clear socioeconomic gradient. We did a large systematic review of epidemiological studies in 36 countries, which we published in 2010. There's a very clear socioeconomic gradient. As you go down the socioeconomic ladder, the prevalence of depression and anxiety increases. So this becomes then a question. So what do we do? Should we be addressing poverty? Is this really all about getting rid of poverty? Or can we be doing things to address mental health problems? And my argument is that we need to be doing both. It's essentially a cyclical relationship. And we've seen in previous studies that actually treating mental illness helps people to improve their economic circumstances. So it's not an either or for me, but it's a critical debate. Thanks. Okay, let's move on. So then I think many of you have started to draw attention to what are essentially the principles behind this approach. It's really a population-based approach to mental health. It's an attempt to use knowledge and evidence from research to solve public mental health problems. So we try as far as possible to stick to the evidence of what we know works, to conduct rigorous research, to engage with the political, economic, and ethical dimensions of the choices underlying mental health care. So to ask questions, why do we deliver services mainly in psychiatric hospitals? Is that really where people need to be treated? These are the kinds of questions we need to be asking. The objective is to try and achieve equity in mental health and mental health care. And I think this issue of equity is really fundamental, because we see such massive inequity both in the way in which people experience mental health problems, but also in their access to care. And it also then includes a comprehensive approach, trying to think not only about how do we provide treatment and care, but also promotion, prevention, and rehabilitation and recovery. And then finally, a principle is that mental health really can't be separated from physical health care. So that has implications for the way in which we deliver care and the way in which we detect mental health problems, that we really need to integrate mental health care into general primary health care systems and into general hospitals. So this then raises the question of what do we mean by evidence, and I'd be interested to hear your thoughts on this idea. Ashraf Kaji, who some of you know from Stellenbosch University, and I did this study a few years ago where we interviewed psychology training directors about their reflections on evidence-based practice in South Africa. And we put together this definition. We said the term evidence-based practice has come to refer to those psychological interventions that have been shown by means of empirical research to reduce symptomatology and increase functioning among clients at a rate that is beyond what would have occurred by chance. So this is really trying to get at a way of assessing whether what we are doing is actually effective. Is it actually leading to an improvement in people's mental health, an improvement in their ability to function in their chosen roles in society? So often when we discuss the notion of evidence, there are a number of concerns which get raised, and these are some of the ones that I've heard mentioned quite often. My clients are too complex, I can't measure their feelings. The therapy process is too complex. I'm a therapist, not a researcher. Evidence is a Western construct. It's actually a big pharmaceutical conspiracy, and this whole thing is being imposed on us by big pharma. Or, this is my personal favorite, evidence is epistemologically incongruent with my worldview. So I think these are all important concerns, and we need to engage with them. And I want to present to you some of the counter-arguments that I can think of, but also I'd be interested to hear from you perhaps when we open things up for discussion at the end. So in response to the idea that clients are complex, definitely, of course, clients are complex, and of course the therapy process is extremely complex. But increasingly it's becoming possible to measure outcomes, to measure whether as a result of people receiving psychological therapies, their emotional states improve, their cognitions change and improve in a way that meets with their own personal goals, their behavior changes, We can measure reductions in symptoms using various instruments, and there's a whole host of instruments out there. We can also measure improvements in functioning, and that refers to people's ability to conduct day-to-day activities, to live a life that's meaningful and important for them. There are a range of different ways, especially in this emerging field of global mental health, that these things are starting to be measured. Often paying very careful attention to culture and to local meanings, but at the same time trying to develop measures. The key balance is between accurately capturing people's experience, but also being able to develop measures which can be generalized and about which we can say things about populations as a whole. It's also possible to measure processes, and these include both non-specific elements like psychotherapeutic rapport, empathic listening, reflection, engagement with a client, as well as specific techniques, for example, specific behavioral activation techniques or cognitive reframing, which are aligned with a particular therapeutic modality. And I'd really encourage you to have a look at this book if you're interested. This is something I came across in the late 1990s, which really sparked my interest in this whole idea. It's called Escape from Babel, and it's really an attempt to try and say, well, can't we think in broader terms across therapeutic modalities? We have psychoanalytic people doing work over here, we have CBT people doing here, we have problem-solving therapy and behavior activation people over here. Are there common elements in all of our approaches, and what are the active ingredients which lead to changes and improvements in our clients? Some other counter-arguments. I really believe quite firmly that you don't have to be a researcher to use evidence in your therapy practice. You just need to be able to evaluate evidence, to work out what is good or valid or reliable evidence, to keep an open mind, and to keep learning during the course of your whole career. And I've put up this picture. It's a picture of an intervention really called the Friendship Bench, which has been developed by Dixon Chibanda, who's a Zimbabwean psychiatrist. And essentially, over a process of a number of years, they've gone about literally putting benches in the gardens of primary care clinics in Harare, and training lay community health workers to deliver brief problem-solving therapy, normally of around 2 to 3 sessions in duration. And through funding initially from Grand Challenges Canada, they've now been able to conduct a large cluster randomized controlled trial, which has been published in JAMA, of all things, the Journal of the American Medical Association. Really well-powered, well-designed randomized controlled trial, which has shown astonishing effects, massive reductions in depression. They've also developed a local, this is really a nice part of the story, is they've developed a local culturally valid outcome measure called the Shawna Symptom Questionnaire, which Vikram Patel was involved in developing in the 1990s, and that was the primary outcome. So I think it's so great that they used the Shawna Symptom Questionnaire, and they published it in JAMA, for goodness sake. I mean, isn't that amazing? So the good thing is that they've now engaged with the city health authorities, and now this is part of what you can get if you go to a primary care clinic in Zimbabwe. I think also this story serves to illustrate that evidence really isn't a Western construct. People who believe that it is, first of all, don't read history and haven't yet joined the 21st century. So there you have it. So why is evidence important? Well, I think it's important not only from a public health perspective. First of all, the public health reasons. We want to, as a policymaker, we would want to achieve the best population level impact for the resources that are invested. So if I have a limited amount of money to invest in mental health care, I need to know that it's actually going to have an effect on the population. For example, if I want to treat substance abuse, what is the best evidence for how I can treat substance abuse in communities? Secondly, for clinical reasons, I think it's really important that we provide care for clients that yields the maximum possible benefit for them, that reduces their clinical symptoms, that improves their functioning, that allows them to engage in the activities that they choose to or that they think are important in their life. Thirdly, I think evidence is very important for ethical reasons. It's unethical to provide care for an intervention or a practice for which there is no proven benefit. So we may think that taking a crystal, attaching it to a piece of string and dangling it in front of our clients' eyes is going to lead to some benefit for them. But unless that has actually been proved to be beneficial, that's not necessarily an ethical way to proceed. And then finally, and I think this is a very important part of the whole story, is that for advocacy reasons, we need evidence to support budget allocations. We need to be able to go to policymakers like Tracy Naledi and say, we've done this trial, we've shown that if we provide counseling for antenatal women, it leads to an improvement in their depression. It may even lead to improvements in their children's health outcomes. That's really powerful for them, and that provides them with very compelling evidence to allocate budgets. And then finally, I thought I'd put up this slide, which these two mathematicians trying to work out a complex formula. And the one says, well, they're right there, then a miracle occurs, and the one says, I think you should be a bit more explicit here in step 2. This is really about, trying to be thorough and careful and pay attention to what works. So why should we then be including this public health way of thinking in psychotherapy practice? I think first of all, because it can equip therapists to examine and understand the broader system within which they deliver services. Secondly, I think it's very important to strengthen the role of therapists as advocates for appropriate evidence-based mental health systems. I think certainly when I was doing my training back in the mid-1990s, there wasn't really a sense that as psychologists we had really any potential impact on the health system out there. I mean, I think we felt very disempowered, and I think that's how many practitioners feel, is that you're a cog in the machine and you're just working away. But I do believe, actually, from experience of having engaged in policy processes over the years and having worked for the WHO for a few years, that we can actually have a big influence on the way in which services are organized and the way in which budgets are allocated. And then finally, and this gets on to the model of care, I think we need to strengthen the role of mental health specialists, whether psychiatrists or psychologists, as trainers and supervisors. If we're going to be using non-specialists, for example, like community health workers, someone has to take on that critical role of supervising them and training them and making sure that what they're delivering is good quality care. And that's a critical role for all of us. Okay, so let's take a step back now and talk a little bit about the kind of global picture. And this is really just to give you a sense of some of the kind of global policy debates and how this has started to emerge as an important issue in recent years. So the burden of mental and behavioral disorders is growing, largely driven by population level demographic changes. The latest global, actually there is more recent global burden of disease data. This is from 2010. The 2015 data has just been published. I need to update my slide, but it's not changing dramatically. Around 7.4% of the global burden of disease was attributable to mental and behavioral disorders in 2010. And this increased staggeringly by 38% from 1990 to 2010. So this is driven largely, as I said, by demographic changes. If you take an age standardized burden per 100,000 population, it doesn't change that much, taking all mental disorders together. But because the population is aging and because the population is growing, we're seeing a growing proportion of the total burden which is attributable to mental disorders. And by the year 2030, it's predicted that unipolar depression will be the second leading cause of health disability in the world. It's also related to changes in the burden of disease and the reduction in infectious diseases and the emergence of chronic non-communicable diseases. But the spending on mental health really doesn't match up. So services are generally underfunded in most countries. Sheikha Saxena, who's the Director of Mental Health and Substance Abuse at the WHO, says when it comes to mental health, all countries are developing countries, and I think he's absolutely right. 28% of countries have no specific mental health budget at all. 37% spend less than 1% of their health budget on mental health. And of course, when it comes to developing countries, and especially African countries, very few countries spend more than 1% of their meager health budgets on mental health. And in fact, most of that 1% in African countries will go to the psychiatric hospitals. There's very little in primary care, very little in decentralized general health care. There's also a policy and legislation vacuum. Over 40% of countries have no mental health policy. That's 53% in Africa. And there's no mental health legislation in 25% of countries in the world, covering around 31% of the world's population. And of those countries who do have mental health legislation, around half have pre-1990 legislation, so a lot of outdated legislation. So the human rights protection for people living with mental health problems in the world is extremely inadequate. So that's the bad news story. If we stood there, we would get very depressed, but let's move on. There's some very nice developments which are happening. Gro Harlem Brundtland, who was the Director General of the World Health Organization in 2000, introduced for the first time, every year the WHO has a World Health Report, and for the first time in 2001 it focused on mental health. And so that was really a landmark event, because it was a real signaling of WHO's intention to start thinking more carefully about mental health and to take the burden of disease associated with mental disorders more seriously. And in the years that followed, the WHO went about developing a policy guidance package, which is a series of training materials and documents to help countries to develop national mental health policies, to develop strategic plans for mental health, to budget, to design information systems for monitoring mental health care, to plan human resources. There are about 14 of these modules. There was one on child and adolescent mental health, which Alan Fisher was involved in writing. And these resources have been used very widely by countries around the world. In 2007, there was a Lancet series. Many of you probably know the Lancet, which is one of the leading medical journals in the world. For the first time, had a series on global mental health, and that was led by Vikram Patel. Some of you may have heard of him. Really worth looking at his TED Talk on global mental health, which is very inspiring. So he was one of the leading people behind that, and that series made a call to scale up mental health services and did a costing of what it would cost to scale up mental health services at that stage in 12 different countries. It also launched a movement, an NGO called the Movement for Global Mental Health. And then in 2008, the WHO launched its MHGAP program, which is a clinical guideline for use by primary care practitioners to detect and manage common mental health problems. And it's mental, neurological, and substance use disorders. So it includes epilepsy, includes substance abuse. And that is now used, this MHGAP is now being implemented in around 90 countries around the world, which is really very exciting. There were further academic attempts to try and work out what the packages of care should be in a PLOS Medicine series. There was a second Lancet series on global mental health. And then in 2011, Pamela Collins and colleagues published after an extensive Delphi consultation process, published an article in Nature on really the research agenda for global mental health, which I think has then set the stage for a whole host of new research funding. Grand Challenges Canada poured 32 million Canadian dollars into research on mental health in low-income countries. In the years that followed, DFID have put a lot of money in. NIMH have put millions of dollars in, really to try and find solutions for low-resource settings. So this is all very exciting, and it's an exciting time to be working in the field. The WHO launched its Global Mental Health Action Plan in 2013, and every 2 years, it's doing a global survey of resources in the world. And then I was fortunate enough to attend this very exciting meeting which happened in Washington, D.C. last year. This is Jim Yong Kim, who's the president of the World Bank. I mean, who would have thought the president of the World Bank saying mental health is important? So the meeting was titled Out of the Shadows, Making Mental Health a Global Development Priority. They're really trying to link mental health with other development issues like poverty, violence, inequality, and so on. And Dan Chisholm and colleagues from the WHO did a costing, and they worked out for every dollar invested in care for depression and anxiety disorders, there would be a $4 return on investment over the period of the Sustainable Development Goals up to 2030. So let's bring it a little bit closer to home, and many of you will know this story, so I won't go into it in too much detail. But since around 2012, our Minister of Health, Dr. Erin Motsoaledi, who you can see in the top right-hand corner there, has really been pushing the area of mental health and has been actually quite a strong advocate. So he launched a series of provincial mental health summits, which I think many of you here in the room attended. In early 2012, around 4,000 stakeholders from around the country attended these. And this culminated in a national mental health summit in April 2012, just outside Pretoria, which then led to what was called the Ekurhuleni Declaration, and subsequently to a new mental health policy and strategic plan, which was adopted by the National Health Council in July 2013. And subsequently there was a technical advisory committee for the minister, which was established, and really quite a strong commitment to include district mental health teams in the pilot National Health Insurance district sites. And I don't want to go into this in too much detail because I want to leave some time for discussion, but these are the main sort of objectives of the policy framework. You can download it from the Department of Health website. It really focused on developing district-based mental health services, and this is the overall model, which is really very similar to the WHO model, which has as its basis self-care, then informal community care delivered through NGOs, traditional healers, faith healers, church groups, and so on. Then primary care services, and then above that, psychiatric services in general hospitals, and community mental health services, and then really at the apex of the triangle, long stay facilities and specialist hospitals. So as you go up the pyramid, the population level need for care decreases, but the cost increases. So this is the ideal. The reality is probably mostly upside down, right? So most of the resources are probably concentrated here. So this is the challenge. So I just wanted to talk about PRIME in conclusion. So PRIME is a DFID-funded research consortium working in Ethiopia, India, Nepal, South Africa, and Uganda. And it's really, the focus of the work is on this statistic, which says that in low and middle income countries, around 75% of people who have mental health problems don't get access to care. So it's really focused on trying to narrow this treatment gap, as it's called. And essentially in each country we've established a district demonstration site where we're trying to develop a district model for mental health care. I'm not going to bore you with all the details of the purpose because I've just said that more or less. It's a partnership. We lead it here from UCT, and they've given me the funny title of CEO, but really it's a partnership of really an amazing group of people. And Vikram Patel, who I mentioned earlier on, is one of the two research directors. And he said the most exciting thing about PRIME is the fact that ministries of health in 5 countries and the WHO have joined mental health research leaders as equal partners. And we've really tried to build this into the structure of the whole consortium. So in each country we have a principal investigator who's based either at a university or an NGO, and then a Ministry of Health partner. And the Ministry of Health partners come to all our annual meetings. Even before we had the funding, we got some seed funding to hold a meeting, and we invited them and we asked them, what are your priorities? What should we be studying? So policymakers are very involved with this. And it's a great group. That group has stayed more or less consistent. I'm not going to go into all the details of the principles. It's really focusing not so much on what, but how. How do we take what we know works, evidence-based interventions, and deliver them in low resource settings. It's using this WHO MH Gap Guide, which I mentioned earlier on, and we're focusing, limiting ourselves to adults. Sorry, Sue, but hopefully the next one will be with children and adolescents. But it's alcohol abuse, depression, psychosis, and epilepsy. These are the country sites, really quite diverse in terms of their size and also in terms of the availability of mental health resources. And we've gone through 3 phases over the last 6 years. We've now been funded for another 2 years, which will take us up to 2019. Initially, we went through a process of developing a mental health care plan for each district, working with the local stakeholders in each district. And then we implemented it over a 3 to 4 year period, and we're now taking that model and scaling it up to other districts. And I want to speak specifically about the South African site. This is the overall structure of the mental health care plan. So we thought it's very important not just to go in and train primary care workers at facilities, because we know just training alone doesn't have a big impact, but also it's very important that we try and intervene on the health system level. So we've worked with district health managers to introduce them to mental health, to convince them about the importance of mental health, to make sure that we have information systems that are integrated into the primary care clinics. We've trained primary care nurses, mainly nurses, in the clinics using the MH-GAP guide, plus primary care doctors in some settings. And then very importantly, we've also tried to set up community level interventions to try and really provide support, family support, and also to try and stimulate demand by using community-based case detection methods. And I can tell you more about that if you're interested. So the site for South Africa is in the Northwest Province. It would have been much easier if they'd asked us to work in the Western Cape or in KwaZulu-Natal. The South African team is led by Inge Peterson, who's at the University of KwaZulu-Natal. And she has worn a well-worn groove between Durban and Klerksdorp over the last 5 years. A lot of traveling back and forth. She has a wonderful team working in Klerksdorp, and One Silo Hilwe, who was at our psychotherapy meeting the last couple of days, presented, and she's just fantastic, dynamic, rising star. We're working, as I said, in the one district, the Kenneth Kaunda district, which is in the red in the Northwest Province, and it's really using this this national health insurance model to try and say, well, how can we integrate mental health into the primary care platform? We went through a process of running what we call theory of change workshops with the district health management team and the local NGOs. And you can see here, this is the theory of change. This is Inge over here. Theory of change is really a way of mapping out a kind of causal pathway from your point of entry into a system to the outcome that you hope to achieve, and making sure that you're very clear about what your assumptions are along the way. So it's no use training primary care nurses if no one's going to come to the clinic for depression, if no one even understands their problem as being depression. What are you going to do? So just really making sure that all those steps along the causal pathway are clearly mapped out. We've used a tool called Primary Care 101, which has actually been developed by a team here at the Lung Institute, and which integrates mental health. And this is the overall, this is what I really wanted to talk about, because I think this is potentially most relevant for discussions about NHI. So this is our model. The primary care nurses are really the case managers. They're really at the center of the care model. They detect people with depression using Primary Care 101. They provide brief supportive counseling. They check on repeat medication where necessary. But crucially, they refer to these people, the behavioral health counselors, who are lay community health workers, supervised by psychologists, and they deliver the counseling, which is normally 3 to 6 sessions of largely problem-solving therapy, very practical, helping people to manage their moods, developing ways of trying to address some of the common practical problems that they have. And we found this, we've now followed cohorts of individuals, and Inge and her team are now doing a large cluster trial, but at least initially in the cohorts we see very, very nice responses and reductions in depression symptoms. Doctors, so it's basically a stepped care model. So the primary care nurse detects somebody with depression when they're coming for either HIV or hypertension or diabetes treatment. They are then referred to the behavioral health counselor. If they don't respond, they're then referred back to the primary care nurse or directly to the doctor, and the doctor will then prescribe antidepressants. And the psychologist's role, and this is really the interesting part, this is what I'd be interested to hear all your thoughts on. The psychologist's role is to provide training, supervision, and also a referral source to see complex cases. But they're really providing oversight for the system. And if you want to read more, Inge's now published in the British Journal of Psychiatry the actual mental health care plan, which sets out the sort of nuts and bolts. We're now taking this model to other districts. We've gone to the neighboring Bojanala district in the northwest, Gatsebande district, and Amajuba in KwaZulu-Natal. And we're working closely with the Department of Health on this. So I'm just going to conclude by sharing with you, this is the slide I mentioned that Tracy Naledi put up for a potential Western Cape model for counselling services. So we have here different levels of care. These are community-based services, step up and step down facilities like William Slater and Crick Lund, and then primary care clinics and community health centres, district hospitals and the psychiatric hospitals. And this describes the services that are provided at each of these levels, who the main delivering agents are of the service. So it's community health workers, registered counsellors, lay counsellors, school health nurses in the schools, and then a psychologist at the district hospital level and a psychologist at the tertiary level. But for each of these service providers, there are clinical governance people who oversee the training, supervision and support of these people who are largely delivering the service. So that's the model that Tracy's put up. Again, we can discuss it. If you're wanting to know more about our research, we've got websites and lots of resources which you can look at, and these are the people who've been funding us. So thank you very much. Sure, yeah. Okay, thank you very much indeed. Thank you.